Let's talk about this very important topic. Usually there's one MCQ which is asked from this topic every year in the exam. And in bladder, the first thing which I want to talk about is Foley's catheterization and Foley's catheters. So this is a very important topic. I'm sure as interns, all of you must have put catheters in both males and females. So you should know the details about a Foley's catheter. You know that the Foley's catheter is going to have a balloon port. This is going to be your balloon port from where you inflate the balloon. This is the urine drainage port from where the urine comes out. And you have a balloon here as well. And for every Foley's catheter, you have a French grading there, right? The size is according to the French grading, and this French constitutes the outer circumference. It constitutes the outer circumference. It is 2 pi r. So French is 2 pi r, and you know 2 pi r is your outer circumference. This is what is being written in Bailey. So no confusion. It is the outer circumference, not the diameter. Please remember this. And sometimes you can even have a three-way Foley's. You can even have a three-way Foley's. This I've told you in the prostate module where I've spoken about TURBT. I told you that you have an extra channel here for irrigation. And this extra channel for irrigation is used to prevent clot retention. Is used for prevention of clot retention. Now, when I was talking about the French grading, these are the ones which I want you to remember for the exam. Yellow is 10 French, white is 12 French, green is 14, orange is 16, and red is 18. So please remember these 5. These are the ones which I want you to remember. I've already told you French is the outer circumference and not the diameter. Now, there are certain scenarios which are asked, practical scenarios which are asked pertaining to Foley's catheters. One very common scenario is a stuck Foley's catheter. And this happens quite frequently. I'm sure all of you must have experienced this during internship. So you try to deflate the Foley's, but the balloon is not deflating and the Foley's is not coming out. So what do we do in such a situation? Let me share the options with you. Option number 1 is you yank out the Foley's and you rupture the urethra. Well, I'm sure you don't want to do that. Number 2 is you inflate the balloon further and let it burst, but that can also cause trauma. Or you'd carry out an ultrasound guided suprapubic puncture of the balloon. So that is the best management for a stuck Foley's catheter. The best management is an ultrasound guided suprapubic puncture of the balloon. That is what we do for a stuck Foley's catheter. Another scenario which you should know about is that you've supposing put a Foley's catheter in a male patient, and the male patient is satisfied at that time, very happy with you that you did it painlessly. But after an hour or two, the patient calls you back and says that there is pericatheter leakage. He says that doc, that urine is still coming out from the side of the catheter. So what do you do if there is pericatheter leakage? If there is pericatheter leakage, then the options which we have are either to inflate the balloon further. We inflate the balloon further. So some people like to do this. They inflate the balloon further. Or they put a larger size Foley's. These are the two options which you can choose from, either one of them. Now, another thing which I want you to remember, that Foley's catheters can either be a rubber Foley's, and a rubber Foley's is usually kept in place, can be kept for 7 days, and then you need to change it after every 7 days. But there are patients who require Foley's catheterization for a longer duration, right? Especially bedridden patients, they require Foley's for a longer duration, and in those patients we use a silicone Foley's, and a silicone Foley's can be used for 30 to 35 days. And as compared to rubber Foleys, there is less colonization on the silicone Foleys, and UTIs are not that frequent as compared to a rubber Foleys. So these are some points regarding Foley's catheters which you absolutely must remember for your exam. The next topic which we need to talk about is bladder trauma. Now, bladder trauma can be of two types. You can either have extraperitoneal rupture of bladder, or you can have intraperitoneal rupture of bladder. So these are the two types of bladder ruptures which can be there. Extraperitoneal rupture of bladder is more common than intraperitoneal rupture of bladder, and extraperitoneal rupture of bladder can be secondary to pelvic trauma. So if you remember the module on urethral injury, I told you that proximal urethral injury can also be secondary to pelvic trauma or pelvic fractures. So this can be associated, it can be associated with proximal urethral injury. So this can be associated with proximal urethral injury, extraperitoneal rupture of bladder. And there can be blood at the tip of meatus. There can be blood at tip of meatus in these patients. There will be inability to pass urine, and there can be a deep perineal hematoma present in these patients as well. So these are the features of extraperitoneal rupture of bladder. Intraperitoneal rupture of bladder happens when there is blunt or penetrating trauma, to lower abdomen, especially when there is a full bladder, right? Especially when there is a full bladder. So let me share an example with you. This actually happened. So I regularly play cricket, and we were playing this corporate cricket league, and there was a guy who was holding on to his urine. So he was eager to pass urine, but he was batting, so he couldn't just go to the toilet. And a fast bowler bowled a ball, and he got hurt just above the suprapubic area. And as soon as he got hurt, he had a syncopal attack, and he literally collapsed on the ground. And when he was taken to the hospital, he was found to have a bladder rupture, an intraperitoneal rupture of bladder. So that is, I just wanted to share that clinical scenario so that you understand when does intraperitoneal rupture of bladder happen. It's less common than extraperitoneal rupture. The clinical features, as I told you, are a syncopal attack as the bladder ruptures. There can be peritonitis and pain abdomen because the urine leaks out into the peritoneal cavity. And of course, there will be inability to pass urine as well. So these are the clinical features of extraperitoneal and intraperitoneal rupture of bladder. The investigation of choice is a CT urography, or CT cystogram. But this can only be done in patients who are stable. So this is the investigation of choice in a stable patient. If you have an unstable patient, we do only a cystogram. So you have to read the clinical question. If they say what is the investigation of choice and they don't specify stable or unstable, you will choose CT urography. But only if they say that the patient is unstable, you will mark cystogram as the correct answer. Now, what is the management of these patients? If you have extraperitoneal rupture of bladder, the management is pretty straightforward. The management is either a Foley's catheter or a suprapubic catheter, SPC, for 7 days. Right? So when do I put a Foley's and when do I put an SPC? If there is an associated urethral injury which I'm suspecting, as I've already told you in urethral injury, if there's a suspected urethral injury, I won't put in a Foley's. I'll then put in a SPC. So that is the place where I'll put in an SPC. If there is no associated urethral injury, then I can put in a Foley's for 7 days. Intraperitoneal rupture, on the other hand, the patient will require a laparotomy and repair of the bladder. I've covered in the general surgery module that repair of the bladder is done in 2 layers. Repair of the bladder will be done in 2 layers. It is usually a round body needle, Vicryl, which is used to repair the bladder. Some people use a second layer of silk over it. Some people just repair it with Vicryl, both the layers. So 2-layer repair has to be done, plus an SPC or a Foley's has to be inserted along with it. So the presentation is different. Investigation of choice I've told you, and the management I've told you. You should remember this for the exam. The next topic which we need to talk about in bladder is bladder diverticulae. Now, bladder diverticulae, you can see in the image, there are 2 diverticulae in this image. So, bladder diverticulae can be of 2 types. You can either have congenital bladder diverticulae or you can have pulsion diverticulae. So, there can be congenital bladder diverticulae or there can be pulsion bladder diverticulae. So, congenital bladder diverticulae are usually seen in the midline. They are usually seen in the midline in the region of the persistent urachus. In the region of the persistent urachus, and their direction is usually anterosuperiorly. Midline anterosuperiorly is where you will see these diverticulae, and they don't assume a very large size, whereas pulsion diverticulae are secondary to increased bladder pressure. They are secondary to increased bladder pressure, and these diverticulae, secondary to increased bladder pressure, this can be seen in patients with benign prostatic hypertrophy or bladder outlet obstruction. Benign prostatic hypertrophy or bladder outlet obstruction. Commonly, they are seen on the side of ureteric orifice. Commonly seen on the side of ureteric orifice. They can increase in size, and very large diverticulae can also block the ureteric orifice. Very large diverticulae can block the ureteric orifice. Right? So this is regarding pulsion diverticulae, which are secondary to increased pressure. So what will be the clinical features of a bladder diverticulae? The clinical features of bladder diverticulae, there will be increased frequency of micturition, increased incidence of urinary tract infections can be there. And another classical telltale finding of bladder diverticulae is that there will be, that patient passes urine, and as soon as he changes posture, he again has urge to pass urine. Why does this happen? Because there is urine in the bladder that the patient empties, but there is also urine in the diverticulum, and when he changes position, that urine in the diverticulum comes out into the bladder and he gets a second urge to pass urine. So this is a classical symptom which one should elicit if you're suspecting a bladder diverticulae. The complications in a patient with bladder diverticulae, there can be stone formation, there can be recurrent UTI, and as I've told you, there can be obstruction as well. If the bladder diverticula is very big, there can be obstruction. Rarely, cancer can also develop in a bladder diverticula. The management of bladder diverticulae is diverticulectomy, but this is only done in patients with large and symptomatic diverticulae. All patients with bladder diverticulae don't require treatment. Only patients with large and symptomatic bladder diverticulae, we carry out a diverticulectomy. The next topic which we need to talk about is the main topic in bladder, that is bladder cancer. Now, bladder cancer can be of 3 types. You can either have TCC or transitional cell carcinoma of the bladder. There can be squamous cell carcinoma of the bladder, and you can have adenocarcinoma of the bladder as well. Now, amongst these three, you know that the most common bladder cancer is transitional cell carcinoma, or TCC is the most common. And the risk factors for transitional cell carcinoma include cyclophosphamide or drugs. You have chemicals or aniline dyes and other chemicals. And another C is cigarette smoking. So you can remember the risk factors of transitional cell carcinoma as 3 C's: cyclophosphamide, chemicals, and cigarette smoking. Aniline dyes, it has been asked in the exam quite frequently, and TCC is the most common type of bladder cancer which is there. Squamous cell carcinoma is commonly seen in patients in Africa, and the risk factors are smoking and schistosomiasis. Right? So 2 S's you can remember: smoking and schistosomiasis. Another point which you need to remember, that smoking not only predisposes to transitional cell cancer, but also to squamous cell carcinoma. Now, schistosomiasis can give rise to bilharziasis, and this condition can in turn predispose the patient to cancer. So it is, in some terms, bilharziasis is a pre-malignant condition which can predispose the patient to bladder cancer, a squamous cell carcinoma. Adenocarcinoma can develop in the region of the persistent urachus, or it can be seen in the region of trigone. These are the 2 places where adenocarcinoma of the bladder can be found. So these are the 3 types of bladder cancers. A couple of words regarding the genetics revolving bladder cancer. This has been mentioned in Bailey. So the NAT2 gene and the GSTM1 gene, also known as the mu gene, the GSTM1 gene or the mu gene, these are the genes which are implicated in germline bladder cancers. Germline bladder cancers, these are the genes mentioned in Bailey. You should remember the names of these 2 genes as well. Now, if we talk about the clinical features of bladder cancer, the patient is going to come with painless, gross hematuria. That is the most common presenting symptom of bladder cancer. This has also been asked in the exam. Now, if you get a patient with painless gross hematuria to your OPD, what is the workup which we are going to do for that patient? That is what we are going to discuss. Now, you know that painless gross hematuria can be a sign of bladder cancer, but can also occur in something like a benign prostatic hypertrophy. So we can't label all patients with gross painless hematuria as being patients with bladder cancer. So the workup is going to include an ultrasound KUB. This ultrasound KUB will tell us if there's any growth/clot in the bladder. It will tell me about the status of the lymph nodes, right? So this is my first line of information. We will do a urine routine and microscopy in these patients. But what you need to remember is that urine cytology has low sensitivity to detect bladder cancer. So what that means is that even if you get a negative urine cytology, that does not rule out bladder cancer for the patient, right? So you still have to investigate further. Doesn't rule out bladder cancer. So to confirm the diagnosis, what do we do? To confirm the diagnosis, we need to do a cystoscopy and biopsy. So that is what needs to be done. You need to do a cystoscopic biopsy to confirm the diagnosis. Now, when we do a cystoscopy, this is the kind of appearance which we get in bladder cancer. Now, when we get this appearance, we are going to take a biopsy or basically excise the lesion we can excise the lesion, and this can be done using cautery till we reach the base, till we reach the base of the lesion. Once we reach the base, then it is very important for you to understand that I will do a cold cup biopsy from the base. Cold cup biopsy from the base. What do I mean by a cold cup biopsy? That I'm not going to use the cautery. When I have to take the base, I will not use the cautery because cautery can then interfere with the histopathological findings. So I'll make a cold cup, cold means without cautery, and I'll send this base separately to the pathologist to know if the base is involved with tumor or not. Right? So that is what we do, and that would help us in determining the T stage of the patient. That would help us in determining the depth of invasion in this patient. So this is how we confirm the diagnosis. MRI can be done for staging. MRI can be done for further staging if we've confirmed the diagnosis. And you have NMP22. This is nuclear matrix protein 22. Nuclear matrix protein 22. This is a urinary marker for bladder cancer. This is a urinary marker for bladder cancer. So this is usually used to check for recurrences in bladder cancer. Okay. Now, once we've sent the biopsy to the pathologist is going to determine the T stage of the disease and if it is cancerous. So we'll get the PT stage, right? What do we mean by the PT stage? That is the pathological stage. Pathological T stage, which is determined by the depth of invasion. TX is when the tumor cannot be assessed. T0 is no tumor. TA is non-invasive papillary carcinoma. This is very important. I'll talk about this separately. Non-invasive papillary carcinoma. TIS is carcinoma in situ. T1 is above the muscle layer. That is, it is involving the lamina propria. T2 is when it invades into the muscle layer. T3 is perivesical tissue. And T4 is when it invades adjacent structures. So that is a simple thing which I want you to remember. You don't need to remember A and B. So TA is non-invasive papillary cancer, TIS is in situ, T1 is above the muscle layer, T2 is invading the muscle layer, T3 is perivesical tissue, T4 is adjacent structures. This is the pathological staging, T stage of bladder cancer, which you should remember. It has been asked in the exam. These are the 8th AJCC updates for bladder cancer. Again, which ones do I want you to remember? So one I want you to remember is T2 staging of diverticular cancers has no T2. I just told you that sometimes diverticular can also develop cancers. There is no T2 for diverticular cancers. T4, prostatic stromal invasion clarified that it must be transmural from the bladder. If it is just subepithelial invasion, then it is T2, it is not T4. Okay. N1 is perivesical lymph nodes. M1 is being divided into 1A, that is non-regional lymph nodes, and M1B, that is distant metastasis. Another thing which I want you to remember, that bladder cancer, you can also have G1, G2 and G3. The grade is also important. G1 is well differentiated tumor. G1 is a well differentiated tumor. G2 is moderately well differentiated and G3 is poorly differentiated tumor. Right, so this is the grading. Also, you should remember for the exam. So we've discussed the staging of bladder cancer. Another thing which I want you to remember, the first lymph node drainage is to the obturator lymph nodes. Is to the obturator lymph nodes. This has also been asked in the exam. Lymph nodes from bladder cancer first drain into the obturator lymph nodes. Now let's talk about the management of patients with bladder cancer. So what you need to understand is that we've already done after TURBT, right? After cystoscopic biopsy, after cystoscopy, and TURBT. TURBT is transurethral resection of bladder tumor. Is transurethral resection of bladder tumor is TURBT, and TURBT can either be done using a cautery or you can use an ND-YAG laser for this. This has also been asked, which laser is used for bladder? ND-YAG laser. So once we've done this, that is when I'll send the tissue to the pathologist and I'll get to know the T stage. Now once I know the T stage, it can either be superficial bladder cancer. It can either be superficial bladder cancer, that means above the muscle layer. That means above the muscle layer, or it can be advanced bladder cancer, that is invading into the muscle layer. That is invading into the muscle layer, right? So superficial bladder cancer, which is above the muscle layer, there can be three scenarios here. You can have PTA, you can have PT1, and you can have PTIS. Now PTA, as I told you, PTA is a non-invasive papillary carcinoma, right? So if the patient has PTA, which is a non-invasive papillary carcinoma on histopathology, then you have two options to manage this patient. Option number one is either we can do observation or we can do a single cycle of intravesical chemo. A single cycle of intravesical chemotherapy, that means chemotherapy which is given inside the bladder, and the agents can be mitomycin C, adriamycin, or thiopita. So these can be the agents which can be used if we have to do intravesical chemotherapy, single cycle in PTA. PT1 is when the lamina propria is involved. PT1 is when the lamina propria is involved, and in these patients, the patient is going to get 6 cycles of weekly intravesical BCG. BCG, you know, is the tuberculosis vaccine. This is from Mycobacterium bovis, and this is given intravesically, right? So you put in a Foley's catheter, you put this drug through that, and you ask the patient to change position every 15 minutes. So 15 minutes patient is supine, 15 minutes on one side, 15 minutes on the other side, 15-20 minutes in the prone position, so that it coats all the area of the bladder, and then the patient is asked to evacuate. So 6 cycles of weekly intravesical BCG. This acts as immunotherapy. This acts as immunotherapy, but some patients cannot tolerate this immunotherapy. They develop granulomatous inflammation. They can sometimes develop TB as well. So if patient cannot tolerate BCG, then intravesical chemo is done. Then intravesical chemotherapy is done in those patients. PTIS is in situ cancer. And if you remember when I spoke about oral cancers and colorectal cancers, I told you that there are three areas in the body: oral cavity, colorectal region and bladder, where there is field cancerization. What do you understand by the term field cancerization? That means the entire area is prone to developing these cancers. And there can be multiple cancers which can arise in the same area. So, in such a case also patient gets 6 cycles of weekly intravesical immunotherapy or chemotherapy. Right, 6 cycles of weekly intravesical immunotherapy or chemotherapy is given to these patients. Now, these patients who have been managed by just intravesical therapy, check cystoscopies need to be done every 3 months. Check cystoscopies, that means you will do cystoscopy to see if recurrence is occurring or not every 3 months, and that is where the role of NMP22, the urinary marker, nuclear matrix protein 22, can also come in, where it can pick up a recurrence early, but you still have to do these check cystoscopies every 3 months. Some urologists, there is a specific subgroup of patients which is PT1 disease, which is grade 3 multiple tumors, right, associated with in situ disease. So PT1, which is poorly differentiated multiple tumors associated with in situ disease. Some urologists offer these patients radical cystectomy. Why are these patients with early breast cancers, this subgroup which has all these, being offered radical cystectomy? Because 40 to 50% progress to invasive cancer, right? Progress to invasive cancer, and it can be then very late. So that is why this particular subgroup can be offered radical cystectomy upfront. This is what is written in Bailey. Now, this was the management of superficial bladder cancer. How do we manage advanced bladder cancer which is infiltrating into the muscle? So T2 is when it is muscle invasion, and T3 is perivesical, T4 is when adjacent structures are involved. Now for T2, we can carry out surgery up front. I will tell you what are the surgeries which are done, and then it can be followed up with chemo and radio. Right? T3, T4, patient will get chemo first. If good response is there, then surgery can be done, and then it can be followed up with radiotherapy. Right? Now, what is the chemo which is given in bladder cancer? So usually T3, T4 are given chemo, and the chemotherapy regime is the MVAC regime. Which has methotrexate. M is for methotrexate. V is for vinblastine. A is for adriamycin, and C is for cisplatin. So C is for cisplatin. That is the MVAC regime which is given in these patients. Now this brings us to the question that what exactly is the surgery which is carried out for bladder cancers? Invasive bladder cancer or advanced bladder cancers. So surgery can either be partial cystectomy. You can have partial cystectomy. This is for a subgroup of patients where you have a small tumor involving the dome, not involving ureteric orifice. You have a small tumor involving the dome, not involving ureteric orifices, those are the patients where partial cystectomy can be offered to them. Otherwise, majority of the patients are going to land up with a radical cystectomy. Now, radical cystectomy would entail the removal of the bladder plus iliac plus obturator lymph nodes. Iliac plus obturator lymph nodes are to be removed. In females, the urethra, and in some cases, abdominal hysterectomy has to be done. And in males, the prostate has to be removed. So this is radical cystectomy, and these days robotic radical cystectomy is being done. I've already spoken about robotic surgery in the minimally invasive surgery module, and I've told you that the robotic surgery has a huge role to play in these pelvic procedures like radical cystectomy. So this is what we remove in radical cystectomy, and once we've done this, once you've removed the bladder, how do you divert the urine? Where does urine go? That is very important for you to understand. Lots of questions have been asked regarding this. So it can either be non-continent urinary diversion or it can be continent urinary diversion. So continent urinary diversion is the creation of a neo bladder, where you create a new bladder, and this new bladder is created using ileum. That is a continent urinary diversion. Non-continent urinary diversions are done more frequently, and non-continent urinary diversions, there can be two options here. You can either have ureterosigmoid anastomosis. Either ureterosigmoid anastomosis can be done, or the patient can have an ileal conduit. I'll talk about an ileal conduit, but you should know that ileal conduit is the most common non-continent urinary diversion for bladder cancer. This question has been asked multiple times in the exam. Most common non-continent urinary diversion is ileal conduit. Right, so ureterosigmoid anastomosis is when you anastomose the ureter to the sigmoid colon. Sounds easy. Now, whenever the patient passes stools, the patient will also pass urine along with it. But it has certain complications because of which this procedure is no longer done. Complication number one is that increased risk of UTI, because you know that the sigmoid colon is loaded with bacteria, and when you're anastomosing the ureter with it, bacteria can travel up and cause infections. Number two, there can be metabolic changes, and the metabolic abnormality seen is hyperchloremic, hypokalemic metabolic acidosis, right? And why does this occur? Because a lot of mucus is produced, and this mucus is rich in potassium and bicarbonate ions. So this potassium and bicarbonate is lost in the fecal matter, and that leads to your metabolic acidosis and hypokalemia, and hyperchloremia because more chloride is absorbed. And the biggest problem with this is that there is 100 times risk of adenocarcinoma at site of anastomosis. I had covered this point in the rectal cancer module as well, that ureterosigmoid anastomosis is one of the risk factors for adenocarcinoma of the colon and rectum at that site of anastomosis. So that is why ureterosigmoid anastomosis is no longer done. These days, in most of the patients, we carry out an ileal conduit. Now, what exactly is an ileal conduit? This is the ileum. Okay, this is the ileum. Let's arbitrary, just let's label it into 3 segments, A, B and C. It's just an arbitrary division. This is the blood supply of all the 3 segments. Now what I'm going to do is I will isolate segment B. I will isolate segment B, and to maintain fecal continuity, I will anastomose segment A with segment C. So that fecal matter can go forward, anastomose A with C, we anastomose. B we have isolated. This ileum which we've isolated, one end is going to come out as an ileostomy. I've already covered ileostomy in the small and large bowel module, so you'll get it out as an ileostomy. The other end we close. This is our segment B which we had isolated. This is the blood supply. And I'm going to anastomose the ureters into this ileal loop. The ureters are going to be anastomosed into this ileal loop now. So what is going to happen? Now urine is going to come out through the ileostomy which is here, and it is going to get collected in a bag. So then patient is going to pass urine through that bag which is connected with the ileostomy, right? So this is an ileal conduit, which is the most common non-continent urinary diversion, and the complications of an ileal conduit, you can have necrosis of the ileostomy which you've made. There can be stricture at the site of anastomosis, and this is the most common stricture at site of anastomosis of the ureter with the ileostomy. This is the most common complication which is there, and the metabolic complication can be the same which I've told you for ureterosigmoid anastomosis. Same metabolic complication can be there in this case as well. So this was regarding the surgical management of bladder cancer. One final point which I want you to remember, that the most important prognostic factor for bladder cancer, is the depth of invasion or the T stage. Is the depth of invasion or the T stage of bladder cancer. That is the most important prognostic factor. This has also been asked in the exam. So this takes care of bladder cancer. Now, a couple of small topics which you should know about. First one is Hanna's ulcer or interstitial cystitis. Hanna's ulcer or interstitial cystitis. Now this condition is an uncommon condition which is seen in females. It is seen in females, and the clinical features for Hanna's ulcer or interstitial cystitis, patients come with pain, increased frequency of micturition, and over distension of bladder. When you do a cystoscopy for these patients, when a cystoscopy is done for these patients, you will see a linear ulcer, a characteristic linear ulcer at the fundus. And when we do a biopsy from this linear ulcer, you will see lymphocytic infiltration. Lymphocytic infiltration is seen in these patients. And the management of interstitial cystitis or Hanna's disease is hydrostatic distension, or dimethyl sulfoxide. So just a few lines were mentioned regarding this in Bailey, so I just thought of covering this. One final thing in bladder you should know is acute and chronic retention of urine. Acute retention of urine, and you have chronic retention of urine. Okay. So what will be the difference in presentation and how do we manage these patients is what I'm going to discuss. So acute retention of urine, the patient is going to have a short history. Patient is going to come with pain. There's going to be pain, and you may or may not have a palpable bladder. May or may not have a palpable bladder, right? So, short duration, patient comes with acute pain. Supposing there is a stone which is stuck, or supposing after trauma, there is disruption, so the patient is unable to pass urine. So these are brief histories, there's going to be pain, and the management in these patients is either you put in a Foley's or you put in an SPC, right? But what is important? KFT is going to be normal. The KFT will not be deranged in these patients, mind you. Chronic retention can occur in a patient of benign prostatic hypertrophy, bladder outlet obstruction. These patients, painless, right? And there will be a palpable bladder because there will be huge retention, palpable bladder, longer duration. But what is important in these patients is that there will be deranged kidney function tests here. So deranged kidney function tests, KFT will be deranged. In fact, the urea would be much higher than the derangement in the creatinine. So deranged KFT is going to be there. The management for these patients is also going to be a Foley's or an SPC. Foley's or an SPC, but gradual decompression should be done. Gradual decompression should be done, otherwise it can trigger hematuria. It can trigger hematuria because the vessels can get ruptured. So this is very important. You should do gradual decompression, otherwise it can trigger hematuria. Also, you need to monitor the kidney function tests. And these patients, after decompression, hydration needs to be done because usually these patients are found to be dehydrated. Okay. So after you've decompressed, you start hydration therapy as well. So this is how we differentiate between chronic versus acute retention. I've told you the management. You can be given a clinical scenario, and I've told you the key points of difference of how you can identify the two. Now, before we end this module, just a few questions which you should answer. Bladder cancer, true and false. Smoking is a risk factor for both squamous cell and transitional cell. This is true. TCC is the most common type of bladder cancer. This is also true. Urine cytology for malignant cells is the investigation of choice for bladder cancer. False. It has low sensitivity. We have to do a cystoscopic biopsy. Depth of invasion is the most important prognostic factor. This is true. Superficial bladder cancers not invading into the muscle layer require partial cystectomy. No, false. I've told you the management for superficial cancers. You first have to do TURBT. Then depending on the type of superficial cancer, you may or may not do intravesical therapy. Ileal conduit is the most common non-continent bladder diversion. This is also true. It's been asked in many exams. Bladder trauma, intraperitoneal rupture of bladder is more common. False. CT urography is the investigation of choice. True. For extraperitoneal rupture, only Foley's catheterization for 5 to 7 days or 7 days is sufficient. True. Intraperitoneal rupture of bladder require laparotomy and repair of the bladder in 2 layers. This is also true. So in this module, what is important for the final year students? You need to know about bladder trauma. That can be asked as a short note. Please, bladder stones have already been covered in renal stones in the kidney module. Along with renal stones I've covered. So don't think I've missed out on bladder stones. I've already covered them along with kidney stones. That is also a short note. And you can also have a short note on an ileal conduit. So these are the short notes which you should know from this module. The important MCQs I've already highlighted. Thank you.